Welcome to the module on coding and reimbursement. Now that we have explored all key clinical activities for pediatric transition planning, let's discuss how to get paid for these activities. Before you continue, please print the project-developed transition coding tips. This handy tool recaps the codes for transition planning purposes presented in this module and provides helpful examples. Transition planning is a process that costs time and money, two known barriers to successful transition planning for providers and patients alike. Patients in need of transition planning require comprehensive health insurance benefits that cover transitions care. On the provider side, payment is a crucial element in the promotion of transition planning. Providers need adequate compensation for transition services. Finally, primary care providers' participation in trainings to promote transitions within the medical home requires time and money. It is time to address the elephant in the room. How can you provide coordinated, collaborative transition care in a system not designed to reimburse you for your services? How do you get paid? The best answer is to bill for transition services with current reimbursement codes as required by the Health Insurance Portability and Accountability Act, or HIPAA, which insurers recognize. Knowledge is power when it comes to evaluation and management, or E&M coding and documentation. Payment for services, optimal compliance, and avoiding external audits by payers all require accurate coding. Using current procedural terminology, or CPT codes, appropriately is important for a variety of reasons, including 1. Insurers track CPT code usage to develop a claims history. 2. Calculation of appropriate managed care depends on accurate CPT ICD-9 codes for every visit. 3. Although your level of reimbursement is linked to a claim's CPT codes, you need to document a symptom, diagnosis, or complaint, an ICD-9 code, to establish that each service provided is reasonable and medically necessary. Also document physician time spent addressing the patient's needs, including phone conferences with the patient, family, specialists, and other providers. Here are some reimbursement tips to use when billing for services for patients with complex conditions. For patients who require prolonged service, care coordination, and more frequent visits, 1. Practices should appropriately use higher intensity codes. For example, Level 4 or 5 for acute problems or chronic condition follow-up, with documentation to support these codes. 2. Determine if your practice appropriately uses higher intensity codes. Compare the distribution of CPT codes for all patients versus those for patients with complex conditions. The distribution should not be similar. 3. Document all services for medical decision-making or care coordination, including phone calls and correspondence. Both can financially drain a practice with many patients with special health care needs. Bundle the time into the face-to-face visit as applicable, or report separately if appropriate. However, there are time restrictions for bundling. Generally, the lapse should not exceed 1 month from the date of service. 4. Become a DSCC medical home provider, as described next. The University of Illinois at Chicago Division of Specialized Care for Children can be a third-party payer. DSCC may reimburse for qualified care coordination activities to manage and develop care plans for medically and financially eligible children with special health care needs. The Transitions Resource List provides a link to the DSCC's publication, Reimbursement Guidelines for Medical Home Services, available with other information about reimbursement on their website. We strongly encourage medical home practices to learn the qualifications for coverage and how to bill for care coordination services provided to their DSCC patients. Providers outside of Illinois may look up their Title V agency online to determine if they offer reimbursement. Planning for transition services may occur over several visits in conjunction with regular care or in a dedicated appointment. When transition planning occurs in conjunction with regular care, include documentation for E&M services based on the 3 key components: history, physical exam, and medical decision-making. Billing for time is an appropriate way to receive reimbursement for face-to-face transition planning services. Care coordination must exceed half the visit face-to-face time. Bill for physician time only. While a practice cannot bill for a care coordinator's time alone, The added efficiency of the coordinator frees the pediatrician's time for more patients, which increases overall revenue. Documentation must include the total length of time and a description of the issues addressed in counseling and for care coordination. Recall that the insurer's calculation of appropriately managed care depends on accurate and pertinent CPT and ICD-9 CM codes for every visit. This includes documentation of symptom, diagnosis, or complaint to establish that service is reasonable and medically necessary. In addition to these suggestions, it is also a good idea to get to know the insurers who serve your patient population. They can inform you on how to bill appropriately for services provided. As described in the AAP Medical Home Coding Fact Sheet and the project-developed Transition Coding Tips, here are some common codes to bill for pediatricians' time for care planning, such as transition planning. All codes and descriptions are subject to changes in healthcare laws. Not all insurers pay all codes. Row 1 of this table shows codes 99211 through 15 to bill for physician evaluation and management, or E&M services, for established patients and/or families seen in a face-to-face or other outpatient visit. These codes allocate minutes for physician time based on problem severity. Medicaid reimburses for them. The severity and time factors range from 5 minutes for a minimum problem to 40 minutes for a moderate to high severity problem. The modifier 25 may be appended for significant, separately identifiable E&M services and is frequently used for time spent with patients with special healthcare needs. Row 2 displays similar codes for new patients. Row 3 shows the codes for consultations for new or established patients. These do not apply to Medicare patients. Minute allocation is based on problem severity. You must meet specific reporting criteria and include the 3 R's: request for consultation, rendering of opinion or advice, and written report. Note that the patient need not be physically present for these codes. For example, they apply when a parent meets with the physician to discuss the patient's needs. In this case, time is the key factor, and you disregard history, exam, and medical decision-making. Such a setting, without the teen involved, may be more relevant for transition discussions that also involve guardianship or patients with intellectual disabilities. Please take a moment to review the codes shown here and then continue to the next slide where the table continues. Here are some codes for non-face-to-face transition planning. Examples of services include care plan oversight, review of reports and lab results, research, and family provider discussions by phone or correspondence. Report services once per 30 days. The codes for non-face-to-face prolonged services can occur either before or after the face-to-face service, but must be reported on the same date of service. You cannot double report using both sets of codes shown here in separate rows. Check out the AAP Medical Home Coding Fact Sheet and the project-developed Transition Coding Tips for more detailed coding information. When billing for time, use additional minute values to choose the CPT codes from this chart. Use these codes for prolonged service minutes reported in addition to the E&M code for the level of visit. Finally, be aware of other codes reimbursed by some insurers for services such as team conferences. For example, use code 99367 for a team conference involving the physician and subspecialist for 30 or more minutes. Here are some codes for care coordination services and transition planning covered by Medicaid in Illinois. Follow the link to HFS, where you can download the current Healthcare and Family Services fee schedule and modifier list for practitioner fees. Providers outside of Illinois should look for a similar fee schedule on their state's Medicaid website. Here is the first of 2 care coordination coding examples for patients with special healthcare needs. Recall that it is important to substantiate the need for care coordination and complex care planning by including all pertinent ICD-9 codes in the documentation, not just the ICD-9 codes related to the reason for the visit that day. In this example, the primary care provider created a portable medical summary, provided other physician supervision, and completed care plan oversight activities for 17-year-old Johnny, who has cerebral palsy. Practice staff used code 99340 and reported with the codes shown here for care provided in the month of July. The physician's billable time included developing Johnny's portable medical summary, reviewing a power mobility evaluation report, reviewing his swallow test results, and identifying and talking with 4 potential adult-oriented primary care providers to determine their willingness, ability, and fit for assuming Johnny's adult health care. The second care coordination coding example involves 16-year-old Jenny, who has spina bifida with hydrocephalus. Code 99358 was used and reported with the pertinent ICD-9 codes to substantiate the need for care coordination and complex care planning. The physician's time was spent in evaluation and care management following the patient visit for healthcare skills assessment and goal planning, including discussion with wound care center, review of a cystogram, review of Jenny's completed transition checklist, and follow-up in collaboration with the spina bifida nurse coordinator. Discussions ensued about self-catheterization compliance and ways to promote healthcare self-management skills. Here are some general tips for establishing office procedures to improve reimbursement. 1. Conduct periodic coding sessions for staff to ensure understanding of correct codes. 2. Update encounter forms to include CPT and ICD-9 codes that reflect the patient population and to remind staff to include the appropriate code for the diagnosis in the documentation. 3. Design progress notes into templates with a space to record actual amount of time spent in order to ensure adequate documentation of services. Remember, if it is not documented, it did not happen. 4. Use a tracking sheet to document time spent on non-face-to-face care. 5. Realize that codes may not be reimbursed by all payers or in all cases. For example, 99339, 99340, 99214, and 99215. 6. Have policies in place regarding payment by the family when a claim is denied. 7. Consider tracking which insurance carriers reimburse for which codes. 8. For codes that are paid by some insurers and not others, you may be able to negotiate with non-paying insurers by providing documentation that other companies are paying. For codes that are sometimes paid and sometimes not paid by the same insurer, find out what causes it to not be paid. And finally, 9. Communicate helpful transition reimbursement tips with ICAP staff to share with other members. Here are some resources to help you with coding and reimbursement. Of special note are the AAP Medical Home Coding Fact Sheet and the project-developed transition coding tips already described. The fact sheet highlights commonly reported codes for medical homes and is updated annually to provide current coding information. The transition coding tips recaps the billing codes presented in this training in a one-page PDF file, which can be printed for easy reference. Additional coding and reimbursement tools continue here. The AAP Coding Hotline, available with membership or a subscription to the AAP Coding newsletter online, provides email responses to specific questions. Staff who work for AAP members may also inquire, but will need the provider's AAP ID number.